Hello, I'm Christina Faull. I'm a consultant in palliative medicine in Leicester, and I'm going to talk you through some of the aspects of caring well for a patient who has limited English, particularly in the context of palliative and end-of-life care. So as professionals, we have a duty to help people have appropriate information to make decisions about their care and give consent to things that we may be seeking to provide as part of their care. The GMC tells us that patients must have this information and it has to be shared in a way they can understand and retain, and that may include using an interpreter or a translation service if they have difficulty understanding spoken English. The NMC similarly states that nurses must make steps to meet people's language and communication needs. Sometimes we need an interpreter who shares the language with the patient and also speaks our language, English, to help bridge so that we get effective communication. It empowers the patients, it promotes the active participation in their making choices. And this is so important in end-of-life care. Where does someone want to be? What do they feel about the symptom management drugs that we may be choosing to use? All of these things are very difficult conversations with patients where we share the language. So an interpreter can help enable that. They can help us understand various elements of the cultural context that the patient and the family is in that we may be blind to. And moreover, it is absolutely important that we comply with equality legislation so that we're not disadvantaging people by not providing an interpreter. I find it useful to have a structure for my consultations, and I use this acronym ABIDE, thinking about arranging the interpreter, briefing them before we go in together or on the phone together, the actual interview itself, a debrief afterwards, and evaluation in case there are points for me to pick up. There are some particular things to remember in arranging the interpreter. You need to know how to do it in your organisation, both for face-to-face and for telephone interpreting. Finding out exactly what language the patient speaks can be a little tricky. There are some guides to that. I've shown an exemplar here. Seeing if there is a gender requirement for the interpreter, and of course on the form you're filling in, or the E approach to the service, you'll need the date, time, location, and giving a brief overview of the context, particularly if it's an emotionally sensitive. So if you're going to talk to someone and their family about the fact that they're not responding to treatment and that you think they're entering a palliative, an end-of-life phase, then the interpreter needs to be forewarned about that so that they also can emotionally cope with that. Remember that discussions with an interpreter can take longer. So for instance, if it's an outpatient appointment, you'll need to arrange sufficient time for that. It is incredibly important in palliative and end-of-life context to have a meeting with the interpreter before, be that on the phone or face-to-face, because the conversation is going to be complex and sensitive, and it's very difficult to solve problems during the interview. So briefing and agreeing the roles of people during the interview is really important. If it's a face-to-face consultation or interview, then the positioning can be quite important, so that you and the interpreter are positioned so that the patient can face you both. You obviously want to talk to the patient or the family member and not to the interpreter, keeping them as a central focus. Not least so that non-verbal elements of communication are transferred. And allow time at the beginning for the interview for the interpreter to make the introductions. They need to be done by the interpreter, why they're there, who you are, and what the role of the interpreter will have in this interview. Talking with the interpreter after the consultation is really helpful. They're an invaluable member of the MDT and can bring you a lot of perspectives as to whether the interpreter thinks the patient really took on understanding of the things that were discussed, what may have been apparent to the interpreter in any discussions that weren't in English between the patient and their family, for instance, to help you really understand the context for this patient. Also reflecting on how the consultation went, whether you worked effectively with the interpreter, and how the interpreter is following what can be, of course, quite a sensitive consultation with emotions being shown by the patient and the family. Does the interpreter need any support? Then some self-reflection is really important, because this is a skill and it is challenging to develop, and there's always ways to improve. You may want an observational assessment of you working with an interpreter as part of this to get some feedback from others, but self-reflection is really important too. So just some summary tips. Seek the patient's consent and make sure one is booked is acceptable. Gender, language. Identify the patient's language. Brief the interpreter about the context and the key content or tasks of the consultation. Make sure the interpreter understands terminologies such as hospice, palliative care, often not translatable. Expect the consultation to take longer. Keep messages and language simple and debrief with the interpreter. And the contrary to that is, of course, don't do things like make assumptions about the language. Just because they're from India doesn't mean that they will speak Gujarati, which is the commonest language in Leicester. Don't use Google Translate for health-related discussions, but fine to use for things like, would you like a cup of coffee or tea? Try not to look at the interpreter, but rather look at the patient when you're speaking to the patient. And do regard the interpreter as a part of the team and not just a automaton or AI for translating your language. And remember, they may be affected. I hope this has been useful to you. If you want to explore more about supporting people from diverse ethnic backgrounds, please take a look at some of the resources on the LOROS website and in the e-learning for health ELCA, that stands for End of Life Care for All resources, where there's a learning program to support equality, diversity and inclusion. And just to acknowledge that this was funded by LOROS and by Marie Curie.